So congratulations to Xiaoling Chen for putting together this fantastic meeting, and it's a great honor to be invited this year to present at CBS 2020 on air. I'm Dr. Khan. I work as a consultant interventional cardiologist in Birmingham in the United Kingdom. So I'm going to share today with you a case of bifurcation stenting during primary PCI. So just to give you some background, this is a 66-year-old gentleman. He's presented with retrosternal chest pain. As you can see, he's got anterior ST elevation and also lateral ST elevation on his ECG with some inferior ST segment depression. So he was brought directly to our cardiac cath lab for primary PCI. Now, knowing that this is more than likely to be an LED lesion, I went up immediately with a guide catheter. This is a radial approach, and you can see that the LED has a large burden of thrombus. There is TIMI1 flow in the LED with an occluded proximal diagonal branch as well. Now, the LED was wired with a workhorse wire, and after inflating with a 2.5 balloon, I was able to establish some flow down the LED. Now, knowing that this is probably an important diagonal, it comes off very early. There aren't any other major diagonals coming off this LED. I elected to put a second wire down and just gently inflate the ostium of this diagonal with a 2mm balloon to see if I can assess its size and also its significance. Now, once we did that, you can see quite clearly that this is a very important diagonal branch. It has extensive atherosclerotic disease involving not only the ostium, but further down the vessel as well. So we're dealing here with a Medina 011 bifurcation. The branch is also sizable in its diameter, more than 2.5 millimeters, and it also extended round quite far round the lateral wall, which is probably why we were seeing the ST elevation in the lateral leads as well. Other important things here to note are, of course, the bifurcation angle, which is less than 45 degrees. We already have established that this is a very thrombotic lesion. So the question in our mind really was, should we plumb for a single provisional stent strategy here, or should we consider a 2-stent strategy up front for this gentleman? So given these important factors, we felt that actually a 2-stent strategy up front is probably what we should be doing for this gentleman. Now, what I didn't want to lose is my LED wire, so I elected to do a DK crush procedure during the setting of this primary PCI. So what we've got here is a stent in the diagonal. This is a 2.5 stent. This was deployed and then balloon crushed to high pressure with this 3.0 non-compliant balloon in the LED. Now, wiring the diagonal to perform my first kissing balloon, however, did prove a little bit difficult. So you can see eventually I had to reach for a hydrophilic whisper MS wire, and I was able then to get that through the proximal strut of this diagonal stent. I opened the stent struts and then performed my first kissing balloon inflation with a 2.5 and 3.0 non-compliant balloons. Now at this stage, unfortunately, we had no reflow in the diagonal. However, after I inflated a 2.5 balloon in that diagonal, I was able to establish flow back into the diagonal. And at this stage, given the extensive thrombus burden, I elected to give a glycoprotein 2B3A inhibitor to this gentleman. The LED was then ballooned and then subsequently stented. So this is a 3x24 stent going into the mid-LED segment, followed by a 3x38 drug-eluting stent to the proximal LED. Now you can see I didn't want to trap my hydrophilic wire in the diagonal between 3 metal layers. So I pull that out, and before I optimized with my 3.5 non-compliant balloon in the mid segment of that stent, and then performed POT more proximally. Rewiring was easier, so this is a workhorse wire that I was able then to get back into the diagonal. We've of course created a large lumen in that ostium of that diagonal, and I performed my second kiss and finished with a POT. So we were certainly in a better position than when we had started. We've got good flow in the LED and diagonal. There is, however, an edge dissection here, also extensive thrombotic disease extending down into the apex. So this dissection was then covered with a overlapping 2.5 stent. So we were very pleased with our result. We had TIMI3 flow in the diagonal and also in the LED. I then performed the RAO cranial wire out shot. And at this stage, we realized that there was something, a bit of a miss in the diagonal here. And what you can appreciate here is that there is extravasation of contrast, more than likely due to a distal wire perforation in one of the branches of the diagonal. So whilst we were thinking about what we should be doing here, I rewired the LED and diagonal, performed balloon inflation in the diagonal to get immediate tamponade. I asked for an echocardiogram, and reassuringly it didn't show any evidence of pericardial effusion. The gentleman also was hemodynamically stable. So whilst the balloon was up, of course we're dealing with a type 5 perforation on the modified Ellis criteria. So whilst the balloon was up, we were just considering our options. In terms of perforation management, obviously inflated balloon immediately to cause tamponade. If there is pericardiocentesis required, this is probably the time to perform it, and you will do that if there's a hemodynamic compromise of your patient, particularly tamponade or features of tamponade. In our case, we didn't need to notify the surgeon. The options then depend really on whether this is a large vessel perforation or, as in our case, a distal vessel perforation. In a large vessel perforation, you're going to consider a covered stent. In a distal vessel perforation, you have more options available to you. You can think about embolization, either with coils, with fat, gel foam, or even thrombin. Very rarely you do have to think about a covered stent over the main, in the main vessel to exclude the side branch. But of course, you're sacrificing then a big segment of myocardium. So we're fortunate to have microcoils available in our cath lab. They come in a variety of lengths and diameters. And these coils have these microfilaments on them, which essentially encourage thrombosis. This particular variety comes with its own dedicated microcatheter delivery system and also a coil pusher. This is a 0.018 of an inch coil pusher. And on the next pictures, you'll see I've rewired the LED and the diagonal. I've got my microcatheter down, and I'm deploying these microcoils through this microcatheter. This is the coil pusher. It's radio opaque. Then you've got a radiolucent segment. And the coils are then just gently packed in as distal as you can go, really, to ensure that you're not putting too much myocardium at jeopardy. So a total of 3 coils were deployed here, 3 by 2 millimeter, and then 2 lots of 2 by 2 millimeter coils. The coils don't work immediately. You do have to be patient with them. Sometimes you have to inflate a balloon proximally in the diagonal to allow thrombosis to occur. So when we did that after a period of time, very pleasingly, we realized that we had sealed this perforation. And of course, during that whole time, we were performing echocardiography to ensure that we don't need to put in a pericardial drain for this gentleman. So it's important to realize that actually when you have a perforation, you can also get leakage from the other side as well. Here, this is a large dominant right coronary artery, but there was no suggestion of a leak when we took an acquisition here. So my take-home messages on this case are we don't really know what to do with important bifurcations in the setting of a primary PCI. Should we consider an upfront 2-stent strategies as we did here, or should we adopt a provisional approach and consider only bailout stenting, in which case you'd have to probably resort to a T or a TAP stenting procedure. You always have to be cognizant of the fact that distal wire perforations can occur, particularly if you've used hydrophilic wires. And of course, we know from the data that there's an increased propensity with the use of glycoprotein 2B3A inhibitors. Coils are particularly helpful. We've demonstrated here they can bail you out in the cath lab from potential disasters. They are quite easy to deliver, and this case was done after the perforation had developed within half an hour. I'm pleased to say the gentleman went home on day 4 and is doing well when he was reviewed back in clinic. Thank you very much for your attention, and I look forward to your questions. Thank you.